Thank you, Pablo, for the nice introduction. Thank you, Imad and Vlad, again for the invitation to join the webinar. I enjoyed very much and I learned a lot already. So this is a presentation of a case with a giant ICA aneurysm. And Imad wrote to me, I want to see a challenging case. I would love to have it again, to do it differently. So this is a case what I love to have it again. And you will see why. So this is a 45-year-old male. He was on vacation here on the Baltic Sea with his wife and his 10-year-old son. And suddenly he had first time severe headache. He took some aspirin and then it becomes a little bit better. And then again, it is third day, again, severe headache. So that's why he came to our emergency department and was admitted to the hospital. And he reported about his 3-day history of severe headache, but neurological, he was completely fine. Then of course, what we do, we make a CT scan. And then you see here, oh, oops. You see a lesion. It's without contrast, so it's a hyper dense lesion in the CT, suspicious of hematoma formation. Of course, we make a CTA in the same setting, and you see, obviously, there is a thrombus, and it is a partially thrombosed ICA aneurysm. Here you see the 3D reconstruction, shows the carotid and the big aneurysm. So what we do, of course, we want to know, did he has a small warning bleeding? So he got a lumbar puncture. CSF was completely clear, no erythrocyte, and also no zero phages. So there was no history of previous hemorrhage or an acute hemorrhage. Then, of course, we have to make in DSA to have a precise understanding of the aneurysm. And you see carotid here, big aneurysm, carotid going up here, here. So then, of course, what you do with a patient, we explain to him he has a giant aneurysm. It did not bleed, so it's no emergency case, but we advise to him to have a treatment. And you may agree that surgery is the best option, although nowadays maybe we would opt for a flow diverter, which could be sent here because we have similar cases, and it's astonishing when the aneurysm is completely disappearing and the ICA looks almost normal. But at that time, there was no flow diverter available. So I thought we can do microsurgery. Maybe we have to do a bypass. Maybe we can clip it. But of course, you have a high risk of the surgery. And so on Friday, I explained to him, and he should think about it over the weekend. And then I took the consent of him, explained everything to him. And then we scheduled the surgery for Tuesday because on Monday I had a large tumor which had also symptoms and required a lot of collaboration with other specialties. So we scheduled him for Thursday, and I thought of Tuesday. So I think it is good for him that he can think about it because, you know, with the surgery, something can happen. He's now completely normal, and after the surgery, he may wake up paraplegic or hemiplegic or something like that. And then on Monday, he went to the anesthesiologist to get the informed consent about anesthesia. And while he was talking to the anesthesiologist, he suddenly had again severe headache and he vomited. But he said no, after a while he said, no, it's okay, everything is good. And he continued with the consent. And then he was brought back to the ward. And when he arrived, he suddenly became comatose with 6 fixed and dilated bilateral pupils. And then, of course, we make immediately a CT, and you see a massive hemorrhage, which Fisher grade 4 subarachnoid hemorrhage. What we do, of course, immediately, we rushed to the OR and make a large flap, and you see the red and angry brain is visible. So we exposed here, you see optic nerve, this is the carotid on the right side. And then we try to dissect the neck of the aneurysm. This is A1, optic nerve. And then you see the hemorrhage is at the neck of the aneurysm directly when it was arising from the carotid. So probably it was an anterior choroidal aneurysm originally. So what we do, we put second suction in, small patty on the rupture side. And then I placed a temporary clip on the proximal carotid. Then I had temporary clips on the MCA and ICA. Then I opened the aneurysm. And you see still some blood coming, probably from the PCOM. And then a big clot comes out of the aneurysm. So then we can fold the aneurysm together. And we have an understanding. So it was exactly at the origin of the anterior choroidal artery, but I could not preserve the vessel because there was exactly there the rupture. So we have this fenestrated rectangular clips, and I made a clip reconstruction of this broad-based aneurysm to reconstruct the carotid. So 4 clips were required to close this neck. Then I removed the temporary clips. Temporary clip from the MCA, ICA, and finally from the internal carotid artery. Then you make a flow measurement. It was a good flow. Then we did angiography. Initially, I thought it goes the different way because this was enhancing earlier, but this is related because the wall is thinner than here. That's why it was running the wrong way. This one day after surgery, you see the swelling, you see here, infarction from the anterior choroidal artery territory. We made the angiography. So there's a good reconstruction of the ICA. But you see after 14 days, you see that he had already an hypoxic damage of the brain because of this increased pressure immediately due to the rupture of the aneurysm. And 3 months after surgery, you see almost the whole brain is gone everywhere. So it was a disaster, and he remained in vegetative state. And then 6 years later, he died, but it was a disaster case. So what would I do differently? Just 1 day earlier the surgery, and we could prevent this disaster. So this was one of my worst cases, which I will never forget because he was really a nice guy. But I thought I should give him some time to think about because he was completely neurological intact. And of course, if you have such a large aneurysm, you have the risk that he has some deficits. And everybody will say, well, why? He was completely normal. And I could not think about it. But he really said, no, I want to have it here. I don't want to go home. Let's do it here. Just I had this case on Monday. So in retrospect, I should postpone the day on Monday to Tuesday and make it. So I'm curious to hear your comments. Thank you for your attention.
I think, Henry, you need to blame anesthesia for that.
Yes, that is always easier.
Well, that's where the rupture happened, right? When speaking to anesthesia.
Exactly.
Thank you so much, Henry, for your honest presentation and waking us up about this important issue. I don't know if our colleagues want to comment on something.
Yeah, may I? Thanks, Henry, for that case. A very valuable lesson to learn. But I'm not sure whether I would have rushed into going for an operation on the same day, especially you haven't seen any subarachnoid hemorrhage on the initial CT scan, and also the lumbar puncture was negative. So I probably wouldn't have rushed him on a Friday for a major operation like this. I think it was the right thing to do. It was, in my view, he was extremely unlikely to rupture on the day before the operation. But I forgot, did you do a formal DSA or was it CT angiogram?
No, I showed it was a DSA.
Okay.
We did in DSA.
Yeah. I can't think of anything else I would have done differently apart from doing it earlier, but which I would have done it on a Monday, Tuesday in any case.
Yeah, Monday would be better. Just Monday.
No. That's only because you now know what happened on Monday. That's not fair. Because he could, if you had scheduled it for Monday, he maybe would have vomited and bled on Sunday.
Yeah.
I had an exactly similar case of a very young man. He didn't want to have the surgery. He had a slight oculomotor palsy. That was the only thing, and that improved. But that were the warning signs, the headaches and so on. There is something going on with that aneurysm. Something is in the wall of the aneurysm is going on, and it's increasing. And actually, when he finally decided to go for surgery, it was on a Friday, and I said, we don't do it on a Friday. And I rescheduled my CP angle surgery on Monday for that surgery. And on Sunday night, shortly after midnight, he was found dead in his bed. He bled. So you never know that. You never know it. And if you rush earlier into it and you would have a complication, people could blame you and say, why did you rush? He had no neurology. So why was it so necessary to do this so quickly if that would be an intraoperative rupture at the neck and having clipped the anterior choroidal at that time? So it's all the ways around. It is difficult. And this is the hard part of it's a hard piece of cheese to swallow.
Yeah, it's difficult. But I think there was a kind of dissection in the wall. I think this was the cause of the severe headache.
Yes.
And then there was another dissection, and then suddenly it bled. This is my theory.
Is symptomatic.
Henry, I would say that was pure bad luck. You know, we all have the similar cases. I have a brainstem cavernoma who bled 2 hours before scheduled surgery. Brainstem cavernoma, you know, and this is the complication which I call management complication. But you only know this with the hindsight.
Of course.
That you made a mistake.
Yeah.
You know, should you be operating on a case earlier and he would be hemiplegic, you would be showing the same case, telling us that you made a mistake on rushing him too early to surgery.
Yeah,
that's nothing wrong with this.
May I, Henry? I have a very similar case. It was the mother of a friend of mine, and it was I give to them 2 days to think about for the family and so and so. Was completely intact, and she was found dead in the bed during the night. So this is something that you said early, you do, better it is. On the other hand, I have a suit case, a medical legal case, where the accused was that the consensus was done the same day of the surgery. So, you know, I don't think that you can feel if I did in a different way. I think that you did the right decision. Leave 24 hours to think about and give the consensus 24 hours before. And unfortunately, the aneurysm was against you, against him.
Yeah. All right. Thank you for the comments.